Uttam Chaudhary and you are watching Uttam Studies. Today in this video we're going to discuss about remaining part of jaundice and deeply about phototherapy and exchange blood transfusion. So before watching the video, please like, share, comment and subscribe the channel and don't forget to press the bell icon to get the notifications. Thank you.
So, in this video, we're gonna discuss about jaundice and about phototherapy. As you all know that earlier I already discussed about meaning of jaundice, definition, pathophysiology and metabolism of bilirubin and types of jaundice, causes and risk factors. These points earlier I discussed in my previous video and I already shared the link of my previous video in the description. Now in this video we're going to discuss about neonatal jaundice, that what is neonatal jaundice, signs and symptoms of jaundice, diagnostic evaluations, treatment, complication and preventions. These all points we are going to discuss in this video. So we start from here, the neonatal jaundice. The neonatal jaundice is yellowing of eyes and skin of newborn due to excess of bilirubin. Here in this picture you can see clearly this is a healthy baby and this is a baby suffering from jaundice. You can clearly differentiate these two pictures, that the baby suffering from jaundice looks yellow in color, means his or her skin color is yellow. As you all know that during pregnancy, placenta is the connection between the fetus and mother by which transportation occurs. Transportation, you can say the nutrients, minerals and oxygen are transported to the baby and the waste product is excreted from the baby. So during pregnancy, bilirubin is excreted from the baby's blood via placenta, but after the birth, baby's liver take over this job and liver have to perform this function. Liver have to remove this bilirubin from baby's body. About 60% of full-term newborns and about 80% of premature babies have clinical jaundice in first week of life. This is the data that is about full-term, 60% full-term and 80% premature babies are suffering from jaundice. Clinical jaundice in neonates is seen at bilirubin level more than 5 mg per dl. This is a, you can say this is a criteria by which we can diagnose this condition. If the bilirubin level is more than 5 mg per dl, then the baby is suffering from jaundice or is at the risk for the jaundice. Now here we discuss about the types of jaundice in neonates. First is physiologic jaundice. Second is pathologic jaundice. Third is breast milk jaundice. And the last is inadequate breastfeeding jaundice. The physiologic jaundice occurs after 24 hours of the birth, but the pathologic jaundice occurs within 24 hours of the birth. Breast milk jaundice occurs after, or you can say in between 5 to 7 days, and inadequate breastfeeding occurs in between the 5 to 15 days of the life. These breast milk jaundice and inadequate breastfeeding jaundice are not so serious conditions. These are but the physiologic and the pathologic jaundice are a little bit serious condition. So we're gonna discuss about these physiologic and pathologic jaundice. Here we are going to discuss and we can differentiate these two easily. In physiologic condition, icterus, as you already know that jaundice is also known as icterus. Clinical jaundice never appears in first 24 hours of life, but in pathologic jaundice, this may appear in the first 24 hours of the life. Physiologic jaundice is, this is not so serious condition, but pathologic jaundice is little bit serious condition. Physiologic jaundice always due to increased level of unconjugated bilirubin, and in this level of unconjugated bilirubin increases and the urine does not stain diapers and no pale stools, means there is no yellowness of the urine and stool seen in this condition, but in pathological situation may occur due to increased level of conjugated or unconjugated bilirubin in our blood. In this condition, Urine is highly pale colored, and stool may be seen yellow in color. These yellowness of urine and stool occurs in this pathologic condition. In physiologic jaundice, palms and soles never stain yellow, but in pathologic jaundice, palms and soles may stain yellow, means yellowness is spread up to palms and soles of the baby. Physiologic jaundice, it does not persist beyond 2 weeks in term babies and 3 weeks in preterms, means this physiologic jaundice cures in approximately 2 to 3 weeks. The pathologic jaundice may persist beyond 3 weeks, means the pathologic jaundice occurs due to any pathologic condition. So we have to treat the pathologic condition and the pathologic cause of this jaundice. Now we are going to discuss about the causes of physiologic jaundice. First is short lifespan of RBCs. You can add RBCs here. In some newborns, the lifespan of RBCs is very short. So because of this short lifespan, early breakdown of RBCs occurs and unconjugated bilirubin is produced in more amount, and this may leads to jaundice condition. The next is immature liver. In the newborns, the liver is not that much mature in comparison to adults. So the newborn liver is not able to conjugate the bilirubin in a satisfactory amount. So the level of this unconjugated bilirubin increases and may leads to this jaundice condition. Next is high level of hemoglobin, that is up to 20 to 22 mg per dl. As if there is more amount of hemoglobin present, then more bilirubin is produced as by increased degradation of this high level of hemoglobin, and may leads to this condition. Now the causes of pathologic jaundice. First is ABO incompatibility, and next is RH incompatibility. Next is if there is G6PD deficiency. G6PD is an enzyme which is responsible for maturation of RBCs. So if the deficiency of this enzyme may leads to pathologic jaundice. Next is if there is any liver disease, that is liver cirrhosis or any fatty liver condition. And the next is obstruction. Means if there is any obstruction in the common bile duct, this may leads to the obstructive jaundice. So these all are about physiologic and pathologic jaundice. Next we discuss about breast milk jaundice. Now you ask, is breast milk also causes the jaundice? Yes, breast milk is also responsible for jaundice in some cases, because breast milk contains some components. These are the components in which first is pregnandiol. This component decreases the glucuronic acid conjugation, means it alters the conjugation process. Now next is fatty acid, which inhibit the activity of UDP glucuronyl transferase enzyme. This enzyme is responsible for formation of glucuronic acid. As you all know that glucuronic acid is responsible for converting the unconjugated bilirubin into conjugated bilirubin, which is water soluble and that can be easily excreted. Next is beta glucuronidase. This converts the conjugated bilirubin into unconjugated bilirubin. So it alters the conjugation process, and you all know that this conjugated bilirubin is water soluble and this unconjugated bilirubin is lipid soluble, so it does not excreted by your body in the with the stool and urine. Next is about signs and symptoms of jaundice. The classical sign is yellowing of eyes, sclera, skin and mucous membrane. Because this yellowness starts from our eyes, because the sclera is highly sensitive to this yellow pigment, that is bilirubin. Then the yellowness spreads up to the skin and then last up to the mucous membrane. Next is poor feeding and loss of appetite. As you all know that this jaundice is a metabolic disorder which alters the metabolic process of liver, by which baby refuse to feed, and so loss of appetite occurs. So this condition occurs, poor feeding. Now next is high pitched crying. As you all know that if baby doesn't feed properly, then baby used to cry continuously. So high pitched cry is there. Next are no weight gain and weakness. If baby doesn't feed properly, then of course weight is altered and weight is not gained, and weakness also occurs in baby. Next is fever. Fever is not the classical sign of this jaundice. It may occur due to any pathologic condition, or in case of pathologic jaundice, it does not occurs in the physiologic or breast milk jaundice. Next is dark yellow urine occurs, and brownish yellow or clay colored stool may present. Clay colored stool is present in the obstructed jaundice. If there is obstruction in common bile duct, then this clay colored stool may present. Next is drowsiness and restlessness, nausea, vomiting, headache, irritability, seizures. These signs and symptoms seen in case of if there is CNS is affected. Means if there is the level of bilirubin crosses 20 mg per dl, and the unconjugated bilirubin is lipid soluble, so it can easily cross the blood brain barrier, so it deposited in the brain cells, and it start to damage the brain cells, and then the central nervous system is affected, and these all signs symptoms present in this situation. And if these signs and symptoms present in the baby, then the condition is very fatal and very serious condition. Now here in this picture you can see the signs symptoms, like baby having yellow skin, and fever may also present, vomiting, diarrhea. These are the some conditions present in, and here the baby suffering from seizures. Next is diagnostic evaluations. Before diagnosing any disease condition, first of all we have to collect the history of the patient, because by collecting the history we get a short idea about the disease condition. In this case we have to ask the mother about gestational age of baby, and we have to weight the baby, and we have to ask about schedule of feeding and nature of crying to the mother. And next we do the physical examination. Then we perform the physical examination. In next slide we will deeply discuss about this physical examination. Next is transcutaneous bilirubinometer. This is a device which is used to measure the bilirubin level in the baby. In next slide we deeply discuss about the physical examination and this transcutaneous bilirubinometer. And here you can see in physical examination we can see the yellowing of the eyes. And next is lab test. In lab test we do CBC, complete blood count, and LFT, liver function test, and we have to check the serum bilirubin level. This is the main diagnostic evaluation, or you can say confirmative diagnostic evaluation of this jaundice condition. The serum bilirubin level in adults and neonates have different values. In adults, the total serum bilirubin level is 0.2 to 1.2 mg per dl. This total means the combination of direct and indirect bilirubin level. Next is direct bilirubin. Direct bilirubin level is also known as the value of conjugated bilirubin in our serum, that is 0.1 to 0.4 mg per dl, and another is indirect, that is the value of unconjugated bilirubin in our serum, that is 0.2 to 0.8 mg per dl. These all conditions in the adults, and now we discuss about this in neonates. In neonates, the bilirubin level is normally higher in comparison to adults because of immaturity of liver. Now, the normal indirect value is less than 5.2 mg per dl in neonates. Next condition is hyperbilirubinemia condition. If the indirect serum bilirubin level is equal to or more than 5 mg per dl, then this condition may be that indicates that our baby is suffering from jaundice or is at risk for the jaundice. Next is if total either conjugated or unconjugated bilirubin level is equal to or more than 12 mg per dl. Here this is a typing mistake. This is not gram per dl, it is mg per dl. Then our baby is suffering from jaundice, and we have to take our baby to hospital for the phototherapy, because this is a higher level, that is 12 mg per dl. Next is if total bilirubin level crosses 20 mg per dl, then this condition is very fatal. This is very serious condition. In this condition, we require a serious treatment, that is a exchange blood transfusion. Later on, we will discuss on this. Next is physical examination. In physical examination, inspection and palpation is done. Palpation is done in some cases. In inspection, Karmas scale is used to determine the extent of jaundice. In this scale, there are 5 grades are present on the basis of yellowness. In grade 1, the yellowness spread up to the face and neck of the baby, and eyes also affected in this situation, that is sclera also become yellow. So this is the grade 1. In grade 2, the yellowness spreads up to the chest and back of the baby, and in grade 3, the yellowness spreads up to the abdomen below the umbilicus to the knee. Here in the up to the elbows and up to the knees, but not below the elbow and knees. In grade 4, the yellowness spreads up to the arms and legs, means below the knees and elbows, but not at the soles and palms of the baby. In grade 5th, that is very serious situation, the whole body of the baby becomes yellow, means the yellowness is spread up to the hands and feet, or you can say soles and palms of the baby. Next is palpation. The palpation is done to determine any pathologic condition, that is to palpate the liver, or in case of liver cirrhosis or fatty liver, or in case of hepatomegaly situation, we have to palpate the liver, and then we get a short idea about this. And next, we have to palpate the spleen. If there is splenomegaly condition, if there is a rapid destruction of RBCs occurs, then as you know that spleen is the graveyard of RBCs, so the destructed RBCs goes and stored into the spleen. So rapid destruction of RBCs may leads to this enlarge the size of spleen, and splenomegaly condition may occur. So we have to palpate this to determine this splenomegaly condition. This is all about the physical examination. Now we are going to discuss about this device, that is transcutaneous bilirubinometer. This is a device used to measure the level of bilirubin in the baby across the depth of skin. In this picture, you can clearly see that this device looks like this. This is a non-invasive device. By this word, that is transcutaneous, we can get an idea about this. That is transcutaneous means across the depth of skin. So before using this device, we have to wash our hand, then we have to clean the this area you can see in this picture with the help of sterilium, because this area comes in direct contact with the baby's skin. Here in this picture, you can clearly see that one medical officer is measuring the bilirubin level in the baby with the help of transcutaneous bilirubinometer. This point of this device comes in direct contact with the baby's skin, and here the reading comes, the level of bilirubin is measured and reading comes over here. This is the very easiest and very safest and simplest method to measure the bilirubin. Now we discuss about the treatment. First and very important thing is exclusive breastfeeding, or to maintain the hydration level. Breastfeeding should never be stopped, because exclusive breastfeeding may help to remove the excess bilirubin from the baby's blood. But sometimes we have to temporarily withhold the breastfeeding if the bilirubin level crosses 20 mg per dl. In case of breast milk jaundice, then in that situation we can temporarily withhold the breastfeeding. Now the next treatment is phototherapy. Here you can, in this picture, you can clearly see the phototherapy machine. In the next slide, we will deeply discuss about this phototherapy. And the another treatment is exchange transfusion. In this treatment is used in very severe situations, or you can say if there is excess level of bilirubin, or if the level of bilirubin crosses 20 mg per dl, or you can say severe hyperbilirubinemia condition, or in which the phototherapy fails. In this situation, we go for this treatment, exchange transfusion. In this next is a drug, that is phenobarbital. This drug is not the drug of choice for the jaundice. Actually, this drug induces the production of glucuronide transferase, which then helpful in increasing the level of glucuronic acid, and which helps to in the conjugation of unconjugated bilirubin. Here we deeply discuss about the phototherapy. In this therapy, a special type of light is used to treat the jaundice by lowering the bilirubin level in baby's blood through a process called photooxidation. This process, photooxidation, adds oxygen to bilirubin so it dissolves easily in water, and then it can easily excreted with the urine or stool. Here in this picture you can see baby lies under the phototherapy machine. This is phototherapy light, and here baby lies. Now we study about the types of phototherapy. There are two types of phototherapy. First is conventional phototherapy. In this, baby is laid under a halogen or a fluorescent lamp. In this picture, here I will show you. Here, in this picture, this is a halogen or fluorescent lamp under which the baby is lying. In this picture, you can see here is a light source under which baby is, lies, and here these are the light sources. From these light sources, light comes and the baby lies under these light sources, and this light converts the unconjugated bilirubin into the conjugated bilirubin, and which can be easily excreted. Here in the conventional phototherapy, if there is only one light is used, then this is known as single unit phototherapy, and if there are two lights, you can see in this picture, are used, then this is known as double unit phototherapy. Here two lights are shown. From these two lights, light comes. Now the second is fiber optic phototherapy. In this, baby lies on a blanket that incorporates fiber optic cable. Light travels through the fiber optic cable and shines on the baby's back. Here you can see this. This is the fiber optic phototherapy device. In this device, this is phototherapy light box, and this is fiber optic cable. From this light travels, and this is the blanket on which baby lies. Here are some pictures. You can clearly see. In this picture, you can clearly see this is the phototherapy light box, and this is the cable from which light travels and goes into the this blanket, and this light shines on the baby's back. You can see clearly in this picture. Now we discuss about some important points about phototherapy. You know that in phototherapy blue light is used. So if light is used, then we have to know about the wavelength of light used and what should be the distance between the light source and the neonate. So the wavelength of light used is in between, the range of this is 430 to 490 nanometer. Here you can see clearly the blue light of range, the wavelength of this light is 430 to 490 nanometer. Now we have to know about the distance between the light source and the neonate. Here this is the light source, and the neonate lies under this light source. The distance between these should be appropriate, not too much far. The baby should not lie too much far from this light source and should not lie too much near to this light source. This is very important. The distance between the light source and neonate should is up to 30 to 45 centimeter, not more than 30, more than 45. And eyes and genital area should be covered with during the phototherapy. Here in this picture you can see eyes are covered and genital area also covered. And the next point is no any ointment, oil, cream should be used during the phototherapy because they may reduces the effect of phototherapy. Next is check the temperature every 2 hourly. This is also a very important point. As you know that baby lies under this light source, so the heat directly comes in contact with the baby. So we have to check the temperature. It's our duty because sometimes baby may goes in the hyperthermia situation. Next is for effective phototherapy, expose surface area of baby, and for maximum exposure to light, frequently change the position of the baby. This is also a very important point. We have to change the positions of the baby, so the whole part of the baby's body should be exposed under this light. Next is exclusive breastfeeding every 2 to 3 hourly. This exclusive breastfeeding is also very important thing. Now next is maintain intake and output charting. We have to maintain this intake output charting. In intake breast about breastfeeding, and output about the urine output and stool. We have to monitor all these things while giving the phototherapy. So while giving this phototherapy, we have to keep all these things in our mind. Next is mechanism of phototherapy. Phototherapy works under these three mechanism. First is photoisomerization, second is structural isomerization, third is photooxidation. In photoisomerization, this photoisomerization is a slow and reversible process, and this structural isomerization is fast and irreversible process, and most important mechanism is this structural isomerization. And the last is photooxidation. This photooxidation is also the mechanism of this phototherapy. Next is side effects of phototherapy. These are the side effects of phototherapy. First is hyperthermia. As you know that baby lies under the light source, so baby's body may heat up. So we have to check the temperature. Next is dehydration. By this light source, dehydration may also occur. Next is skin rashes. By this light may causes skin rashes to baby. These skin rashes are not so harmful, so no need to discontinue the phototherapy. Next is bronze baby syndrome. This bronze baby syndrome occurs if the baby has conjugated hyperbilirubinemia. This bronze baby syndrome occurs, then discontinue the phototherapy for a particular time. Next is watery diarrhea may occur by this phototherapy. And next, these 2 points are very important. That is retinal toxicity and gonadal toxicity. If we do not cover the eyes and genital part of the baby while giving the phototherapy, then these may occur. Next is impaired maternal and child bonding. This is also important thing because the baby lies under this phototherapy, so there may be chances of impair the maternal and child bonding. So we have to keep all these things. Next is exchange blood transfusion. This is also a very important treatment. This treatment is done if the phototherapy fails. The exchange transfusion is the replacement and removal of blood from newborn and infant with elevated bilirubin level in their bloodstream with donor's blood containing normal bilirubin levels. Treatment is indicated for severe hyperbilirubinemia condition, means the increased level of bilirubin. If the level of bilirubin crosses 20 mg per dl, then we go for this treatment, that is exchange blood transfusion. Next, if Kernick teres is there, then we go for this. And if there is erythroblastosis fetalis, which most often occurs with the immune mediated hemolysis. In this process, a small amount of blood are withdrawn and replaced through a umbilical vein. This is a very important point, that for this transfusion we take umbilical vein for the withdrawal of blood and for the as well as for the insertion of blood. So umbilical vein catheter is used to remove partially hemolyzed and antibody coated RBCs as well as circulating immunoglobulins. In these cases we also use this exchange blood transfusion. Here in this picture you can see a medical officer performing this procedure. You can see here he is withdrawing the blood from the umbilical vein. Next, we discuss about the types of this exchange transfusion. There are two types of this exchange transfusion. First is single volume and second is double volume. In single volume, if we transfuse only once of this circulating volume, then this is known as single volume transfusion. If the circulating volume is transfused twicely, then this is known as double volume transfusion. These all are the types of this. Now we discuss about this procedure. In this procedure, blood is transfused on the basis of weight of baby. Here blood volume estimates in term baby, it should be 80 ml per kg, and in preterms it should be 100 ml per kg, means the blood is exchanged on the basis of weight of the baby. Suppose if the weight of the baby is 3 kg, then if we are doing by the single volume method, then we do like this. We take in single volume only the blood is exchanged once, so we take the 80 ml in if the baby is term baby, 80 into 80 per kg, that's why we take 80 into 3, it is approximately equals to 240 ml. It means 240 ml blood is exchanged at a time in a term baby of weight 3 kg by this single volume method. Now we discuss about this double volume. If the weight of the baby is same, then we exchange the blood twicely, that is 2 into 80 multiplied by 3, that is the weight of the baby. We exchange the twicely, and it should be approximately equals to 480 ml. It means in term baby of weight 3 kg, if we are exchanging the blood by this double volume method, then 480 ml blood is transfused and exchanged at a time. Exchange the blood in the small amount according to weight of baby. If the weight of the baby is less than 1500 gram, then only 5 ml of blood is withdrawn, and as well as 5 ml is inserted at a time. And if the weight is 1500 gram to 2500 gram, then we take 10 ml blood for the insertion as well as for the withdrawal. And if the weight of the baby is in between the 2500 gram to 3500 gram, then we take 15 ml blood for the withdrawal and the insertion. And if the weight is more than 3500 gram, that is more than 3.5 gram, then we take 20 ml blood at a time for the withdrawal, and for the withdrawal and for the insertion we take same volume of blood. This is all about the exchange blood transfusion. In single volume transfusion, almost 60% of blood is exchanged, and in double volume almost 80% of blood is exchanged. So this is the most commonly used this method is in the case of hyperbilirubinemia condition. In the after double volume, there may be chances of rebounding of bilirubin level after 4 hours. So we have to keep our baby under the phototherapy for this effectiveness of this. So for this procedure we require a medical officer and a trained nursing officer because this procedure is a sterile procedure. In this procedure, blood which should be exchanged should be whole blood and should be collected freshly, not older more than 5 days. The blood should be fresh blood. So before performing this procedure, we have to check the vital signs of the baby like SpO2, pulse rate of the baby, and pre-procedure bilirubin level. These all things we have to check before performing this procedure. Here this is the picture shows exchange blood transfusion. In this 2 ports are used. You can say these are the ports, and 2 syringes are used, and 1 umbilical vein catheter is used. Here in this picture you can see the blood is withdrawn from this. This is the syringe. If we withdraw 5 ml of blood, then we have to insert 5 ml of fresh blood in the baby immediately after the withdrawal. Here you can see from here the blood is withdrawn. You can see clearly in this picture, one medical officer is withdrawing the blood, and immediately after another medical officer is inserting the fresh blood. This all about the this exchange blood transfusion. Now we discuss about the complications of jaundice. First and the main complication of jaundice is chronic teres. This is very serious condition, or you can say very serious or fatal complication of jaundice. In this, the serum bilirubin level crosses 20 mg per dl. Here you can see if the level of this unconjugated bilirubin increases or crosses 20 mg per dl. As you know that this unconjugated bilirubin is lipid soluble, so it can easily crosses the blood brain barrier, and it reaches into our brain, and it starts to deposit in our brain cells. So it alters the function of brain cells. Here in this picture you can see the unconjugated bilirubin crosses the blood brain barrier and deposited in the brain cells, and it may damage the brain cells and can alter the function of brain cells. It can damage the brain cells permanently also. So if it damages the brain cells, the central nervous system is affected, CNS. If the central nervous system is affected, then the drowsiness, restlessness, and sometimes seizures may occur in our baby. So if the brain is affected, and you know that if brain is affected in any situation, then this condition is very serious and very fatal. This is also known as bilirubin encephalopathy. Now we discuss about the preventions of this jaundice. You know that prevention is better than cure, so we have to prevent this condition by doing all these things. First is exclusive breastfeeding. This is very important. We have to promote the mother for the exclusive breastfeeding. The mother does not have to stop the breastfeeding. Next is health education. This is a very, very important point, because some primary gravida mother don't know how to do breastfeeding, how to feed their baby because of poor knowledge. So we have to educate them about the breastfeeding and about the breastfeeding techniques and about the benefits of breastfeeding. So the health education is very, very important in this case. Next is sun bath. Sun bath is not the you can say treatment of jaundice. This is a you can say this is a prevention. By the sun bath you can prevent the occurrence of jaundice. Here you can say one baby is taking a sun bath in this picture clearly. So at last I would like to say thank you guys for giving your precious time for watching this video. Thank you and have a nice day.